Hello there, I'm Dr. Palmer, and this video series is going to be talking about some of our common mood disorders, including major depressive disorder, anxiety, and some of those related disorders like OCD and PTSD. So, the objectives for the series of videos is to identify DSM-5 or Diagnostic and Statistical Manual text revision of the fifth edition, criteria for major depressive disorder, generalized anxiety disorder. We'll talk about panic, OCD, and PTSD, talk a little bit about the pathophysiology of depression and anxiety, and then talk about the treatment. So we'll spend some time reviewing mechanisms of action, brands and generics, adverse effects or side effects, and things that we take into consideration as potential cautions or conditions that can be a challenge when treating MDD and anxiety related disorders, as well as spend a little bit of time talking about our non-pharmacological or non-medication treatments and complementary alternative medicines. So, major depressive disorder as a whole is the most common type of mental illness that is encountered in the United States, with a 12-month prevalence over 10% and a lifetime prevalence over 20%. So, that's about 1 in 5 individuals. Also, among a young group of individuals, so 15 to 44, it is considered the leading cause of disability in the United States. And this can be due to changes in self-care, loss of productivity, loss of quality of life. All of those kinds of things can really be negatively impacted for individuals who have major depressive disorder. It tends to affect biological females or females assigned individuals assigned female at birth versus males. And we did see some interesting stuff come out of the pandemic when it came to resource utilization and rates of symptomatology for both depression and anxiety that seems to be persisting to some degree into the mid-2020s. So looking overall at the prevalence, you will see that there are a couple different spaces that we see kind of a spike in major depressive disorder, and that's individuals of multiple ethnicities, as well as individuals in that 18 to 25 year range. That's when we see a lot of past year prevalence of major depressive disorder. Looking at anxiety-related disorders, if we group all of those together, they're actually more common than major depressive disorder, but they all have their own individual criteria, so they are considered separately, with phobias being our most common, social anxiety following it by not too much, then generalized anxiety disorder and panic disorder. As you see, PTSD and OCD are actually fairly uncommon compared with phobias, social anxiety, etc. This does tend to affect a pretty young population. So anxiety-related issues can start to be prevalent in children as young as 7 years of age. And it tends to have a bit more of a waxing and waning component than we see with the more episodic and often progressive mental health conditions like bipolar, schizophrenia, etc. When it comes to anxiety-related disorders, again, more common in individuals who are assigned female at birth versus males, and we have those waxing and waning periods with a mean age of onset of 21 years of age for those with generalized anxiety, and 60% of those who are diagnosed are between the ages of 11 and early 20s. However, we do see new onset anxiety in middle age. Right. There is a fair amount of comorbidity or having more than one mental health condition. So 90% of individuals who have generalized anxiety have multiple mental health diagnoses as well. When diagnosing major depressive disorder, the characteristic symptomatology is mood, right? So a depressed mood and or what we call anhedonia, which is when there is a lack of interest or pleasure. So think of like hedonism, right? So an individual who lacks that ability to experience pleasure almost every day for 2 or more weeks. In addition to that, there are 5 symptoms that have to be included in that list. So that mood symptom, as well as some psychological and physical symptoms in addition. We also, of course, always have to think about social and occupational dysfunctioning. So this has to impact someone's quality of life. We want to think about other conditions that can exacerbate or look like depression when we're diagnosing. So when we look at the actual criteria beyond just the depressed mood, so that depressed mood, nearly every day, most of the day, and this is part of a mnemonic, if you like those, called D-SIGI caps. Then sleep disturbances, most commonly difficulty sleeping, but if someone has a more atypical presentation of depression, they may have what's called hypersomnia or sleep a lot. They'll have changes in interest, so that goes back to anhedonia, so diminished interest or pleasure. Guilt, so feelings of worthlessness, excessive or inappropriate guilt compared to the situation at hand. Changes in energy, so fatigue or lack of energy. Difficulty concentrating, so being indecisive, being unable to focus on something. Changes in appetite, typically a weight loss or decrease in appetite, but atypically we can also see an increase in appetite and gaining of weight. And then psychomotor changes, oftentimes slowing or retardation, but we can also see psychomotor agitation. And then one of the, really, they're all concerning, but one of the symptoms that will always be screened for and may elevate someone's treatment level to a crisis type scenario is if someone has recurrent thoughts or death of suicide, particularly if they have means and intent, plan, etc. Right? So there are different kind of levels of suicidality. For generalized anxiety, it actually has a longer duration of symptomatology required for diagnosis. So with MDD, it's 2 weeks or more. With GAD or generalized anxiety disorder, it is 6 months. So 6 months or more. And the generalized part is the important piece here, right? So it's an excessive feeling of worry or anxiety, but for a number of different things. Okay, so it can be over finances and relationships and personal health and whatever, right? But it is over a number of different pieces of someone's existence. And that worry is very difficult to control. It causes dysfunction or impairment, and we rule out other potential causes. The pieces when it comes to specific symptoms regarding the anxiety and worry, we can have some physical symptoms as well as psychological symptoms, just like we talked about with MDD. So feelings of restlessness, or, you feel like you need to pace, or you feel physically uncomfortable in that sense of like can't sit still, being easily fatigued, difficulty concentrating, very common symptom in a lot of conditions, feeling very irritable, feeling tense, even muscle tension, and sleep disturbance, typically difficulty sleeping. Social anxiety disorder is a marked fear or an anxiety about social situations. And of course, we always have to think about, is it an appropriate level of anxiety? So if you are, defending your dissertation or it's your wedding day, it's likely you're going to feel anxious, but this is more if someone is, hanging out with friends or going to the grocery store or sitting on a subway train. And the individual will fear that they will act in a way or show symptoms that will cause them to be negatively evaluated. So any social situation may provoke fear or anxiety, maybe avoidance of those social situations. And again, out of proportion to the actual potential threat. This can cause distress and functional impairment. That is always an important piece of diagnosis, and very similar rule outs when it comes to substances, other conditions, other mental illness. If performance, there are a couple pieces that are added to that specifier, which we won't go into much detail about, but again, 6 months. Just like GAD, those are longer than MDD. Panic disorder is characterized by panic attacks, but you can have panic attacks and not have panic disorder. You can't have panic disorder and not have panic attacks, though. So I have generalized anxiety disorder. I've had panic attacks, but I've never had panic disorder. So we'll define those two right now. So a panic disorder is specified by panic attacks. And panic attacks are a very intense, abrupt, largely physical, but also psychological. With a lot of these conditions, that's true. Sensation that occurs. So this is sweating, increased heart rate, feeling shaky, feel like you can't catch your air. So that SOA or shortness of air, feeling like you're smothering or choking. You can have abdominal pain, distress, feel like you're going to throw up. You can have chest pain or tightness. You can have those that feeling of like lightheadedness, or even feelings of being outside of your own body or outside of reality, which is derealization and depersonalization. People can feel tingly or numb or burning in their like hands or feet or legs, and they may feel like they're losing control or going, I hate the word, but going crazy, right? Or fear of dying. So it is usually something that peaks within minutes. It lasts several minutes to, maybe 30 minutes or so. Some people might have longer panic attacks, but it's not something that lasts for, days upon days. Your body physically probably couldn't tolerate a, 3-day panic attack in most cases. So panic disorders, when you have those panic attacks, and then you have maladaptive changes in response to those panic attacks. So 1 month or more, so different than the 6 months for social anxiety and the 6 months for generalized anxiety, also different than the 2 weeks for major depressive disorder. But there's a persistent worry about having another panic attack or the consequences of having another panic attack. Additionally, someone can have maladaptive changes, oftentimes avoidance. So that thing made me nervous, or I had a panic attack. I'm waiting for the subway train. I'm not going to take the subway anymore, right? And that can lead to chronic avoidance and potentially even what we call agoraphobia, which is a fear of crowds, a fear of open spaces, right? And can bring people to essentially become closed within their homes and unable to really function very well at all. So it can be quite disabling and really uncomfortable. Panic attacks are very, very uncomfortable experiences. Same sort of rule outs that we had before for the other conditions. Now, obsessive compulsive disorder, or OCD, not to be confused with obsessive compulsive personality disorder, which has different criteria and different components of it. OCD is characterized by what we call obsessions and compulsions, thus the name, right? Obsessions are these often intrusive, persistent, recurrent impulses, images, thoughts that the individual does not want. So it's what we call ego dystonic typically. We all have intrusive thoughts, right? So if you've ever been like chopping vegetables and like talking with a friend of yours and you're like, oh, I could stab this person, right? Or, oh, I could just drive off a cliff or what have you. Everyone has those thoughts, in case you're wondering. Everybody has those thoughts. We all think about that kind of stuff sometimes. It's if you're going to do something about it, or if it becomes so distressing that it's all you think about are those like negative, intrusive types of thoughts, that it can become really problematic. But if you've ever had those intrusive thoughts, you are not alone. That's actually completely normal. But if it becomes difficult to suppress or ignore, or causes a lot of worry, then that could be pathological. So a common type of OCD that isn't what we always think of with like the counting and the cleaning and stuff, which absolutely happens, is harm OCD, where people can be very fearful of harming other individuals. That's a common type of harm OCD. So, they are in significant distress thinking that they're going to like stab their friend or something like that, when they're probably the least likely people, because they're so worried and concerned about it. Right? They think that they have an illness that is a compulsion to hurt people, but the illness is in a lot of cases actually the fear of hurting people, so much so that it becomes an obsession. The compulsions are behaviors, so they can be acts, mental acts like counting, behaviors like cleaning, checking, etc., that the person performs oftentimes even if they don't want to, that temporarily relieves or prevents anxiety. Okay. So a lot of times these are related to each other, and a lot of times people have insight into their illness, but that's not always the case. If someone has insight into the lack of rationality of their obsessions and compulsions, their prognosis tends to be better. And in order for these to be considered pathological, we have to think about impairment. And in most cases, the general cutoff is if you're spending more than an hour a day engaging in those obsessions and or compulsions, then that's likely depleting your quality of life. So sometimes we kind of inappropriately say like, oh, it's my OCD, I don't want my food touching. But unless you are meticulously like shuffling your food and you are late to appointments or lose friendships or, experience a significant reduction in your quality of life and functioning because of that, particularness, it's probably just your individual self, right? Same rule outs with conditions and other mental illness. PTSD is a exceedingly long diagnostic criteria, so I'm not going to go through like all of the details of PTSD or post-traumatic stress disorder. Essentially, it is the aftermath of some sort of potential or actual harm. Okay. And anything less than a month is acute stress response. And a lot of people, an acute stress response is fairly common if you get in a car accident or get assaulted or something like that. It's if it persists for a long time or if it appears later on. So some people will essentially kind of tamp down or forget a traumatic memory or event, and it comes back to them sometimes many, many years down the road and causes them a lot of these symptoms. Okay. So the exposures can be direct experience, a witnessed event. So it happened to someone in their vicinity. They also can have potential for PTSD if you're repeatedly exposed to an aversive event and all the details of that event. So thinking like the 9/11 terrorist attacks. So if it's blaring on the news, on the shows, and you just see it and see it and see it, and it starts to negatively affect you. So again, if those symptoms persist a month after the event, then we can consider PTSD. So those symptoms are divided into 4 big kind of clusters, if you will. Okay. And those clusters include re-experiencing, which can be flashbacks, nightmares, recurrent dreams, spontaneous memories that sort of flood into the person's psyche. Avoidance, so they avoid things that remind them. They avoid external reminders. They suppress thoughts about it, so they kind of trying to forget it, essentially. So they want to bring it up into their memory. Additionally, negative cognition and mood. So this can be an inability to recall aspects of the event. It can be irritability. It could be anger. It could be just difficulty concentrating, which is a common symptom that we see for a lot of these. And then hypervigilance or arousal. So that kind of enhanced startle response. Sometimes people want to be kind of able to look at the entirety of a room. So say you go to a restaurant, they want to sit in a very specific place and have to have a visual of the entire space, and they're kind of always looking over their shoulder. They can have irritability and aggression. They can experience sleep disturbances, oftentimes from nightmares, but also just difficulty sleeping. So thinking about recurrence, we're talking about MDD. Recurrence in major depressive disorder, about half of patients who experience major depressive disorder will have a singular episode. However, this is really important to note. With successive episodes, your likelihood of having more increases. So if you've had 3 or more episodes of major depressive disorder, I shouldn't have had in here, MDD. So let me just kind of pop in there. So 3 or more episodes of major depressive disorder. Boop. Where's my button? There it is. This is for MDD. I realized that wasn't necessarily clear. Then you're close enough. Then you are almost guaranteed to have additional episodes without treatment. And they've even studied people who've had multiple episodes. They were on long-term medication for MDD. They stopped that medication, and that recurrence is significant. So we really want to think about risk of recurrence. If someone does really well for 4 months on an antidepressant and it's their first episode, it would be reasonable for them to trial off of it. But if they've had 4 episodes and they respond, in most cases, that risk versus benefit doesn't make sense to come off of that medication. And a lot of these antidepressants have decades of data that support its relative benefit, right? Its relative safety. Nothing is 100% safe. For a really long period of time. We also want to think about other risk factors. So, people who have chronic medical conditions are more likely to experience recurrence, probably because they're experiencing more just general stress, and other comorbidities. So, if you have anxiety and depression, you do have a bit more risk of recurrence. Okay, so next we're going to talk about the differentials, but I'm going to do that in the next video. Thank you.